Healthcare is rapidly evolving, the world is changing every day. How do we keep pace with those rapid changes? And to address those questions, please help me in welcoming Dr. Upali Nanda and Mr. Gaurav Chopra, both from HKS Architects, onto the stage. Can we please welcome them on stage? HKS Architects, ladies and gentlemen, is an international boutique design practice and architectural firm, and they have a presence in over 24 countries all over the world. A very large organization, and they specialize when it comes to architecture and boutique design. A little bit about Dr. Upali Nanda and Mr. Gaurav Chopra before we hand over the stage. Dr. Upali Nanda is a published author, speaker, and researcher with extensive experience in designing, spearheading, and implementing research projects in design practice. Her research focuses on the impact of design on health, on human health and perception. And it'll be interesting for you to know that Dr. Nanda has come all the way from Texas to be a part with us today. Must have been a long flight, 24 hours? 24 hours flight. So she's here with us all the way from Texas to speak to us about what we can look forward to with regards to the ever-changing present of healthcare projects. And Mr. Gaurav Chopra. Gaurav specializes in project delivery using modern tools and techniques, adopting the best practices within a regional context, which is very important because very often an international model cannot be just copy-paste and replicated in a particular country. So how do you take best practices from one region and implement them in this region with keeping the regional context in mind? So it promises to be a fascinating case study. Dr. Upali and Mr. Gaurav, the stage is all yours, and the audience is very keen to know what you have to say.
Thank you so much. Good morning, everyone. Keep it within 30 minutes?
Hopefully.
Yeah. So, if you're not engaged this morning, for those of you who are staying in this hotel and were partying till 1 a.m. last night, it's all your fault. So anyway, I think just getting into it, getting into the meat. When we were contemplating, the good thing is all of us in this room are stakeholders in one way or the other. So, I think, and having said that, Dr. Upali happened to be here. We were having our internal workshop, a strategy and healthcare research analytics workshop. So we felt that, it's perfect timing. How about leveraging her being here and have her explain more about how research and analytics are, shaping the healthcare of today, especially the real estate aspect. So in the next 30 minutes, the way we'll divvy it up is, and I think we're just because we have an initiative going on within HKS, we call ourselves like a boutique design firm that happens to have 24 offices around the world. So our intent here is just to look at, how responsible design is shaping some of the decision making that, helping us craft some of those decision making as we go along. And healthcare is changing by the day. It's not so much about the future, but things that are changing in the ever-changing present. So just moving along, I think for us, as we move along as a design professional, we got to look at how do we create value for all the stakeholders, be it from a CFO perspective, be it from the co-creators perspective, and this room is full of all the co-creators, besides just being projects people, operators, investors. And it's interesting that, we just talked about the B2B, business-to-business connections and having the right people relevant in the room, engage in a meaningful, progressive dialogue. So that said, what we are doing is, it all starts at a very ground level. And, just before we walked in, we saw a quick video here on a snapshot where how cell phones and the individual is changing the dynamics, which could actually impact the real estate because the person wouldn't even have to go to the clinic at the first point of interface, at the first touch point. So the intent is, the way we have geared this talk is, how do we make these informed choices, those informed choices at an individual level have an impact at a community level, which could be, a regional community, and eventually change the landscape at a national or an international level. It's actually happening, and these are some of those guiding principles that are taking us towards making those informed decisions. So our intent is just to keep things simplified, or oversimplifications of things. The first, just defining the today's landscape. What's the purpose? What exactly is the belief and the philosophy of those principles that help us? It's all about designing those processes. Before we even get to the facility part, just designing those processes, the strategies, the expected outcomes, And in our mind, the delivery process is actually a test of those outcomes in reality. Because when we start building a facility, it's actually we are testing all those strategies and principles or the processes that we have thought about, which eventually affect or enable us to, the lessons learned from that delivery become our ammunition for the next definition, for the definition of the next enterprise. So when we talked about the stakeholders in terms of being responsible at this point, given the noise that we are hearing from within the field, it's the user, and the user leads to the community, and then we talked about the co-creators, investors, of course, and especially in a highly, occasionally I do get confused that is India a value-sensitive market or a cost-sensitive market, or maybe a little bit of both. So that's where it comes to the investors. And we will talk, I think, briefly towards the end of an actual live project, which we have undertaken in Delhi, where the earth, the environment, it is playing an active role as a catalyst to help shape the environment given the context of the Delhi, and we'll come to that. So just, I think, Dr. Upali, I'm going to gradually slide it on to you, because I'd like to leverage from your time here in terms of how responsible design is helping us raise the benchmark in terms of design quality, create that industry leadership, and also integrating all the co-creators and all the stakeholders together.
Thank you, Gaurav. So if you look at this quote, which is a bit of an eye chart, you can't read it. It's a quote by Steve Jobs, who says, design is not just what it looks like and feels like, it's about how it works. And if you look at our field right now in healthcare, there is a long distance we need to go before we even get to facilities. We have to identify strategy, finance, operations, understand the human experience, and then you get to the built environment. And I'd be curious right now, at this moment, if you think about what your experience would be if the acoustics were different, if the lighting was different, if the configuration was different, what would change? And what is the one word that we use all the time in healthcare? Outcomes. For us, a lot of this, trying to think of what's the strategy, what is the financial model, how are the operations going to be designed? How do you design operations and human experience before you ever get to thinking about the bricks and mortar is key. So facilities really comes at the very end of this discussion. And a lot of this discussion on what should we do and why we should do it is only possible if you're informed. And you can only be informed if you have research and analytics to back you up. Because how else do you get informed? So it's been an interesting experiment for us. 15 years ago when I graduated with my PhD, if someone had told me you would be directing research in a global architectural firm, I would say you're crazy. If you do a doctorate, you go straight into academia. But it's changed. There is this entire role that has developed because we have to be intentional about the decisions we make. We can't afford not to be. So what our model looks like is focusing a lot on rapidly deployable tools. Academia often has the luxury of making really, really good research findings, but they have a different timeline. When you are designing a multi-million-dollar project, you have to make decisions quickly. So rapidly deployable tools, not only having a large database of research articles, but being able to synthesize the information, having computational tools so that they're actionable. We have our own nonprofit, which focuses on deep dive studies, which have nothing absolutely to do with what we might be doing in practice. We have a current read up, right? So we have a lab, and I'd like to say that we are happy to be guinea pigs. If you have a fantastic idea and you want to test it out, we would love to be the testing ground for it. But the biggest question is you see this evolution and you're thinking about, okay, we do want to evolve. How do we get there? Because it always sounds good in theory. I'd love to see a show of hands. When have you gone to a conference and not seen a presentation about new trends? All right, when have you gone to a conference and seen a new trend that you haven't heard about 5 years ago already? Rarely. You're always hearing about it. How come it was new 10 years ago, and it was new 5 years ago, and it's still new? So how come we're not getting there? What is it that stops us? We talk about disruptive innovation all the time. How do we get there? The trends that we're hearing about, and a lot of the displays outside, Gaurav, were all like that, right? Mobile health, telehealth, a lot about care coordination because the provider mix is changing, a lot around population health and wellness. And then we were hearing about retail health, we're hearing a lot about home health right now, right? everyone in this room can speak to these trends. This is not new for us. We know for each of those, like digital appointments, EMR, electronic medical records, technology integration, we can even make the business case pretty quickly. How much are you going to save in FTE time? How much are you going to save in just operational waste? So again, all of these are things we know. And we've been seeing this image. This is actually Patient Room 2020 that was published 10 years ago. And we're not closer to that. This was in the Wall Street Journal. But wearable technology, mobile apps, digital portals, digital appointments, artificial intelligence kiosks. And this little image to your lower left is actually the Mercy Virtual Clinic. This is the first completely bedless hospital by Mercy. So there are 300 patients, but there are no patients in that hospital. You have completely eICUs and e-monitoring. And this new building, which is a hospital, looks like a Google office. Now, Mercy is very, very intentional. They have figured out that 5% of their patients take up 50% of their revenue. And so these telehealth facilities are for those 5% with extremely complex issues so that they can address them early. Right, but this hasn't become the norm, right? We had a solution, but it hasn't become the norm. The other thing we are seeing is this extending continuum of care. It used to be, we talked about acute care and urgent care and clinics. Now we are talking about healthy and individual lifestyle and a lot about post-acute, skilled nursing, assisted living, home care, hospice. So this continuum has expanded, and we're talking about health and well-being extensively. What else are we talking about? We're talking about data. Everybody's talking about data. Every decision we make is based on data. Now, the research and analytics workshop that we did just 2 days ago, we started with the question, to what extent do you trust the data that you have? Do you have high trust in the data? Do you have low trust in the data? Or do you have no data to trust? And this was a poll, right? We should have polled. So what do you think? If I ask this question right now, how many of you have high trust in the data that you have right now? Not. Sorry? What happened to gut feeling? What happened to gut feeling? That's why you have data to support it or not, right? So how many of you trust gut feeling more than data? Let's do it that way. All right, you just talked about data, Sunny. You just reduced your credibility here. Okay, so a few hands said gut feeling more than data. Not a single hand went up and I said high trust in the data. How many of you have no data to trust? Okay, so then I guess how many of you have low trust in the data that you have? A few more hands, right? In the poll that we did, 100% of our attendees said they had low trust in the data that they have. They have data, but you don't trust it. And what are you supposed to do when you design these really expensive hospitals and healthcare facilities that will stay in place for 30, 40 years? You're basically being asked to look into this crystal ball. Somebody's asking you to look 10, 15, 20, 30 years ahead and say, what's the future going to look like, because I have to design for that. By the time my facility opens, a lot of my predictions today are already obsolete, right? I don't know if any of you have ever seen this. This is the cover of the Reader's Digest magazine in 1966 on what the world would look like in 1999. None of this happened. And no one predicted social media. Not a single future forecast could conceive Twitter, Facebook. None of that was on the radar. So again, we have been asking ourselves this question, saying, for us who are in the business of designing built environments that have to stay in place for many, many years, are we asking the wrong question fundamentally? Should the question really be not how are we designing for this faceless future, but for an ever-changing present? How about we just take change as a given and say, how quickly can I change? Because change is inevitable. Now, Sugandha, give me a time check. How much time do we have?
15 minutes.
Okay. All right, so what we're going to do really quickly, because we do want to talk about a real example at the end of this, is to talk about a study that we did recently, where we posed that question. We said, okay, what are the drivers of change? What are the trends we're seeing in response? What are some case studies? And then we polled the two biggest population, the young millennials and the aging baby boomers, and tried to find out what is it in outpatient care, particularly focused on primary care, that was driving decisions that consumers were making. We started our study calling everybody a consumer. How many of you have been hearing about this, that patients should be treated as consumers? That's an ongoing sentiment that we're hearing a lot. So we started with that. This study, we're going to go through it very quickly. The US findings are available in a completely downloadable report that's pretty extensive, and you can access it anytime. UK findings will be released in January, but we have a little booklet with Sugandha that you can see some of the key findings on. So first question, do patients think of themselves as a patient or a consumer? Quick show of hands on how many people think that a patient thinks of himself or herself as a consumer? Okay. And how many of you think that a patient really thinks of themselves as a patient needing health services rather than a consumer buying health services? Okay. Interestingly, when we did this poll a couple of days ago, it was exactly the same, 50-50 divide. We did this survey as a panel survey, and we asked patients directly, what do you do when you don't have data you trust? You get primary data. You go straight to the source. You ask people directly, and that's what we were trying to do here. So again, very interestingly, 87% of patients said that I think of myself as a patient needing health services, not a consumer buying health services. We talked to a psychologist who told me that, well, it's not surprising because when you're healthy, you don't have the incentive to make health choices. And when you're sick, you often don't have the ability to. And so it depends a lot. If there's specialty services like women and children's, it might look very different because I am choosing very, very early. Certain diagnostic services, it might be very different. But if it's emergency care, if it's critical care, or if it is regular outpatient care where I'm just going to a doctor and I have an extreme condition, I may not want to be a consumer. Does that make sense? So this was interesting for us because we've been using consumer all the time, and we said, not always, maybe that's different. We also asked, and this was true, by the way, more in the UK, right?
Same question.
Yeah, we asked the same question in the UK, and for the UK market, because it's NHS, it was even more so that they thought of themselves as a patient more than a consumer. And this is from the CEO of Welltalk, who says, if you use patient and consumer interchangeably, you're strategically doomed. You have to understand when it's a patient mode and when it's a consumer mode, and design accordingly. We asked, what's more important to you, experience your service? So I don't think of myself as a consumer. However, experience is more important to me than service. I can have the best service, I still want to have a good experience, right? We also asked this question, what do you trust more? Are you someone who trusts in people or someone who trusts in information? And we found that people trust people regardless of how old they are. Even millennials trust people more than information. And this surprised me too. And again, the explanation given to us is what kind of information do millennials trust? It comes from social media. What does social media information come from? People. So it's still people-based information. Somebody was going by word of mouth, and now we are going by word of cyber mouth. But it's the shift of people trusting people. That doesn't go away. Now, these are difficult to read through. And like I said, please feel free to download the report. But we asked the question, what made you select your clinic? What was most important? And the three most important questions, and the graph, the way it reads, is blue is aging baby boomers, and orange is millennials, who are significantly younger. So what were the top factors? Is it covered? Do I get on-site diagnostics? And then very surprisingly, overall cleanliness. You don't think of cleanliness. It doesn't sound like a very interesting topic to think about, but that was a top driver, just cleanliness. When are you the most germophobic? When you're sick. You really, really want to make sure that I'm not getting sicker by going to a place. So this was very, very interesting. If we did this in Delhi right now, it would be all about clean air, right? What's really important to me is clean air. Very similar findings in the UK. And again, on-site diagnostics came up a lot. We also asked them what features make a clinic more appealing to you. Cleanliness and hygiene, walk-in appointments, same-day appointments, that was pretty common. Now, if you'd see the blue bars and the orange bars, without reading through everything, what's the biggest difference that strikes you in the two? You don't get to answer. What's the biggest difference between the two? If you look at the blue bar, there are some things that are very important, and then it tapers down, right? So for boomers, spa-like experience is right at the bottom, there at the end of the graph. Whereas for millennials, that bar is much longer. It's 5th from the top, how important that is. But overall, if you see the orange, they want everything. You don't see a clean gradation. It's like, I want it all. And why not? I think I have it all. I can have it all because I have choices. I love the ketchup example, by the way, that it's that critical number of choices that you can give, which is really, really important. But again, the younger generation has so many choices that they want it all, but a spa-like environment can be more important to them than virtual or video access today, which is very interesting. So every time you are doing a new facility, getting the pulse of your particular patient or consumer type might be very interesting to do. What predicts their return to the clinic? I found this one fascinating. Overall satisfaction was one, which is not surprising. Follow-up care was the other one, which is also not surprising. Wi-Fi connectivity. I go back to a clinic where I have Wi-Fi connectivity. That makes no sense. Where are your priorities? Right? But these are all statistically significant findings. And so again, we are very mindful of the fact that today it's a predictor, tomorrow it might change. What is going to stay constant is this overall satisfaction. Again, in the UK, very interesting, registration process is a big dissatisfier today. If you have a good reg process, they are more likely to come back. And then one-stop shop, satisfaction with labs and diagnostics and having everything in one place. In summary though, if you take all of the variances away, what does a patient really want when they go to a facility of choice is they want to feel like a priority. They want to feel that you were catering only to them, exactly to what they needed. We don't know what this looks like for India though. We are very, very interested in doing the same study in India because this nationwide poll, we did it in the US, we did it in the UK, we saw some variances, but if you're interested in doing it in India, let us know because we are very interested in finding out. Summing it up to those change-ready principles we talked about, number one, for attraction, reputation, convenience, and affordability was key. For retention, for them to come back, low waiting, follow-up care, cleanliness, care coordination, registration, and then Wi-Fi access, which again might change tomorrow when it becomes ubiquitous in any case. Physicians, we didn't go into, we have the extensive report on what physicians want, patient relationships, follow-up care, financial awards, but very importantly, and this was surprising to me, intellectual stimulation. Do your physicians feel intellectually stimulated, and what are you doing for that? This was a very interesting takeaway for us too. Not only to think in terms of footprints, but cloud prints. Have a conversation with yourselves and with your team saying, what's your cloud print today? Is your scheduling going to move to the cloud? Is some of your examination going to move to the cloud? Are you going to see some diagnostics moving, as you are with home health care, more to the cloud? What does that mean? That means your facility will shrink. What are some spaces that are not going to exist 5 years from now? Give me an example. Medical records, for example. Will you have a room for medical records? Maybe not. So today, your medical records room has to become something else tomorrow. Your registration areas, if today they're registration, they have to become something else tomorrow. And you're thinking, because you're thinking, what's that shift over time? And then finally, to sum it up, we had 6 takeaways. The 3 C's, cleanliness, convenience, cost. Cleanliness, convenience, cost, that's central. The idea of the cloud print and the footprint. So you look at a map and you look at a plan and say, okay, what's the cloud? What's moving to the cloud and what is our strategy around that? Are you going to be an anchor for your entire community? And then this idea of connectivity between people, the cloud, and your facility. This unique thumbprint that anybody who comes into this type of facility knows exactly, am I in Max, am I in Apollo, am I in Care? I know exactly where I am. And then flexibility, 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 because we don't know what's going to happen next. You cannot foretell the future. Joint Commission has guidelines for flexibility that go all the way from master planning to adaptation, to robust utilities, and they talk about loose fit design. Don't create a room for everything. Make it flexible. right? What is going to move to the cloud? How can you standardize, think in prototypes, almost create Lego blocks so you can shift things around and add things and take away things and repurpose things. So if I connect it back to what Gaurav said in the beginning, I say, okay, for me to future-proof, I have to be change-ready. For me to do that in a very, very dynamic market today, I have to be responsible, and I have to be responsible to my investors' resources.
I think just in the interest of time, I'm going to move ahead, but
Mike.
can't help but talk about this project that we have undergoing in Delhi, and where, and Dr. Shabnam, you're here, so, credit goes to you and your team for helping us do the right research and at least address those problems which are very much in context to that region. You're talking about change ready. I'm not going to get into these details, but we had a very integrative process. Simply put, we looked at what is negotiable and what's not negotiable just from a process perspective. I'm not going to get into details, but the impact is all that, what helped us with all the data and the information that we had with our partners in crime sitting on the other side of the table. We are aiming to have an impact on the co-creator, on the earth, on the sustainability aspect as one of the metrics. With the biggest challenge in Delhi right now is the air quality. So our sole mission was, let's create a hospital that has the cleanest air in Delhi. And our current energy models indicate that we'll be reducing our PM 2.5 by almost 75% of what its current state is. And it wasn't rocket science. It was just simple laws of physics, and just going through the whole list, we made conscious decisions, informed decisions about our facade choices, energy aspects, processes, creating the outdoor comforts for all sorts of users and so on and so forth. But what that required was, it did compel us to change, bring about a change in our mindsets, and which is pretty much what we are talking about in this context.
And what's fascinating about this project is that, like Gaurav alluded to, that they went with saying, okay, let's not be financially responsible. Let's create really, really reasonable targets of what we can spend, but not lose sight of aspirational goals. You still have a defined budget. The budget has to be optimized. You have to think through the resources you have, but you have to think aspirationally, which is a change in mindset, is to think about the biggest picture and say, okay, I only have this much to spend. How am I very, very strategic and focused in how I spend it? And you have to do that, to think really big picture. Really start with, what's the purpose? What are my innovation opportunities? What do I need to explore? Where do I need to experiment? Where do I go with my gut? Where do I look at the data? If I don't have the data, how do I get it? How do I apply it? How do I execute it? And very, very importantly, especially for those of you who are operating hospitals today, how do I reflect? How do I learn? How do I not repeat my mistakes? By doing assessments of my current state very, very carefully. That's critical for us. It's not rocket science, like Gaurav said. Sometimes it's as simple as take a little bit of time to think about the why. Take a little bit of time to think about that front end and what you need to do. Einstein has this wonderful quote where he says, if I had an hour to solve a problem, I would think about 55 minutes defining the problem and 5 minutes thinking about the solution. And that's really what all of this is about. So with that, we'd like to open it up for questions. Thank you so much for your time. Questions, comments, disagreements?
I want to hear disagreements.
Anyone who would like to share an example of something you're doing that you'd like to see?
Does anybody have a question or comment or a disagreement, as Dr. Upali asked for? No? So in that case, maybe I will play a devil's advocate role.
All right.
Yeah. So, I remember reading an article once about this sort of a similar kind of data analysis, And the one the point which the author of this article wrote was, how is it that everybody says millennials do this, millennials do that? How does that even happen? There are, I don't have exact numbers, but there are probably 1 billion or so millennials, if we have to look at it, if we have to look at everybody born after 1990 or so. How can it be that we can put a blanket statement like millennials want XYZ? And so and the author concluded by saying, next time whenever you see something like millennials want X, millennials prefer Y, take it with a pinch of salt.
Well, that's a fantastic question, by the way. Take it with a bucket of salt. But remember that some things are fundamentally different. You did not have, this generation is growing up with technology. This generation is growing up with different things. There is a reason why we generationally profile, because things have changed. Those who went through the World War went through a different set of circumstances. Those who are digital natives are going through a different circumstance. So the way I answer this question, number one, how we take a billion people's pool and make conclusions, that is statistical analysis, right? You take a representative sample and you analyze it. But the other piece of it is I can have a 60-year-old come up to me and say, I identify more with a millennial than with a baby boomer. I think like that person. And my response always is that means you're a millennial persona. What you're actually doing in talking about millennials and talking about boomers is you're creating a set of characteristics for the kind of users who are coming to you. And some of those users will be the ones who are like, is this spa-like? Do I have choices? I have somewhere else I can go. I have no loyalty. That is a type of person. And another person has come to you who's going to say, I want to trust my physician. I want to know exactly what the pedigree is. And that's another type of person. What this research does is it helps you think about all those different types of people that we call personas and think through that. So yes, let's not generalize, but you're using them because that pattern seems to fit. I'm waiting for the statistics to belie it, but it doesn't. You ask 10 people who were born in the 70s a question, you ask 10 people who were born in the 90s the same question, and you ask my son the same question, some things you will get different responses on, and some things you get the same response on, like when you're sick, do you want your mom? That doesn't change. But when you're sick, do I want to go to my phone and be alone? Or do I want to be in a place where I'm with a lot of other different peer people? That does change. So it's an excellent question because you always want to be critical of the data and ask yourself that, but it's more about personas, types of thinking, rather than really age stratification. Does that make sense?
Makes sense, yes.
Thank you so much.
Yes.
This gentleman.
Let's get a mic there.
It's just a comment for you all to think on. While you build out as architectural firms, you pretty much get a kind of organic growth. So it's clean and you build from scratch. As you move forward, you will have to look at, more often than not, in how do you retrofit.
Absolutely.
And that, believe you me, will be a huge challenge.
Absolutely. Yeah, do you want to answer that?
I think that's something because what is happening is, again, stating the obvious. Mumbai is a very typical example because there's no land and these facilities are legacy facilities. And pretty much lessons learned is that's why when we are starting at any facility for that point, you look at, we're actually first step is I'll try to be loud. It's okay. We do the operational, you've got to do the operational mapping, and that's, before we even start the brick and mortar, because for us, that's the end result. Like I said, that's the test. The brick and mortar is the test of your hypothesis, but what we really need to do is, again, between the clinicians and us, we got to do all the operational mapping first before we get to do that. But good comment. Yeah.
And that's a great point. It also came up a couple of days in that session. And one of the things Dr. Chandrasekhar said, for example, is that's why we have to leverage technology because real estate is going to be at a premium. So there are few things that you're going to do in physical space. And that's this trend that we're seeing towards physical and digital has to be one conversation. Your technologist cannot come later on in the day. It has to be right in place. And when you're retrofitting spaces, you're retrofitting not just the physical space, but the technology that is doing this work of physical presence that you need. Yeah.
Yes and no. Actually, I'll address it when I'm in my discussion. So it's a yes and no answer to your statement.
So I would love to hear that for the panel now, because one of the things I hear a lot about with data and with technology is that there is more noise than signal. And that is a valid concern, but also only spaces like in India, and some person made the comment yesterday when we were presenting that the US is spoiled for space, right? They don't have to think about real estate because we have so much area. we have to think about how we retrofit and work with existing spaces here much more. I'm very curious to hear what you said, because I know that technology comes with a lot of challenges, but one of the biggest challenges is that technology is treated as an independent thing and space is treated as an independent thing, and you create these solutions in different silos. And what if you got everybody, every stakeholder, your furniture person, your technology person, your space planning person, your strategy person, together to solve the same problem? Would that help? Okay. Yes.
Yeah, ma'am. Good morning. I'm Dr. Wani from Yanpoya Medical College Hospital. I had just one comment about, because you asked a particular question about the data, that how do this audience, maybe 100 people, see that data, that it is a trust, high trust, low trust, or nothing. The answer is to you also, even if you calculate. Problem is with you. Now you analyze that problem.
Right.
20% has said we trust, we have low trust on data.
Right.
1% said we have that high trust on data.
Right.
And there were others who did not say anything.
Right.
And all that rest of the lot is confused. In the sense that at times I am telling you, we rely 100% on data, that high trust. It is not that. That is why they are not answering.
Right.
Because if I have, suppose, hospital, I trust my statistical numbers. 100 patients come in OP, this thing, we do 100 procedures, we do this sort of statistics, I trust.
Right.
There is nothing absolutely that I don't trust. This is a high trust thing.
Right.
And then when we low trust, suppose consumables. How many consumables have been used in this type of a particular procedure?
Right.
I have again a low trust. There
Right.
might be some pilferages, there might be some not uses, there might be, so there are n number of factors.
Right. Right.
But what I am saying that this data overall is trustworthy because it is a management tool how to utilize. If I have to give a trust 100% my data, because that time I trust. If I have to give a presentation to a management, I trust data. But when I have to talk to the subordinates, I just fire this, that no, this data is not trustworthy. That is also a management tool. I want to improve.
Right.
Because in my mind, it is just the improvement. What I am saying then ultimately that you just basically see this problem. Why people are not coming clear.
Absolutely.
And why there are issues, there are worries, there are problems in the data system of every hospital. And that has to be looked at, and there may be local factors, might be institutional factors, because you cannot frame any strategy in this country when we are living in India, which is mini world, when we are living in a state. Every state is a replica of the country, and every institution has all other local factors.
Very well
upon
said.
many things. Address those issues.
Very well
institution
said.
by institution, then we can come to conclusions.
Very well said.
Thank you.
And as a researcher, I would respond saying that's one of the reasons that the two things you want to do is first validate, understand that, and I hope you give a presentation on that someday. What does the same data mean to different stakeholders and how you use it differently? I think that's very insightful. But the three pieces of that is you validate what you have. That's your first step, right? So how do you third-party validate? If you don't have it, how do you get primary data? And one of the things that I think nothing can replace is going on-site and learning amongst the people. Oftentimes, we think of data as something secondary that's coming from this ether somewhere. But you learn so much if you're there, if you do diagnostics on-site, so you understand the cultural specificity of even global data. And I think those three things can really help.
And in a country
Yes,
like
hello,
India,
good morning.
even from north and south.
I have
Yeah.
a comment and an observation. There is this book by Eric Topol, talking
Yes.
about the balance of power shifting from the doctor to the patient.
The patient will see you now.
Yeah, because
Yeah.
now we don't necessarily go to another doctor for a second opinion. We go to the internet.
Right.
So with that, with so much information available at our fingertips, and he also made a comment, a very interesting comment in the book. He says that the digitization of human beings will make a parody out of doctor knows best. So what do you have to say about that?
Well, I would agree. And Eric Topol actually tweeted this morning, and he was looking at a paper from 1973 that said, give patients power over their own data. Here we are in 2017 having the same discussion.
Yes.
And at MedX this year, the whole conversation was around P4, preventive, predictive, personalized, and participative care, because the patient, especially in things like oncology, will have so much voice over that. So yeah, I agree completely. It's just such a simple concept. It's taking us so long to get there. And that goes back to the comment that was made earlier, that we have to be respectful of why. Why is it that simple goals are so complicated? Where are the roadblocks that we are putting? And then try to take away one pebble at a time from those roadblocks.
On the participative as well, because nobody knows most about the oncology patient than the patient himself.
True. Yeah, I mean, oncology patients, they do more research than anybody else. They are coordinating their care. So I think that's a really key component. So I agree with you completely. And I think you are going to see the patient being part of the care team. If you look at the oncology research that we'll publish, I think in February, we say the patient is in that provider team. They have a voice because they are looking at clinical trials all over the country, all over the world. And they want access to their own data. There are lawsuits going on right now saying, why do I not have access to my own data?
Yeah. So it's just ripe for disruption.
Absolutely.
Thank you.
Ripe for disruption.
Thank you so much.
Excuse me. Doctor, one question, please. Here. Yeah, hello. I've got one question.
We are around here. How about that?
Just because sorry. Really appreciate one point what you spoke about, the cleaning of the hospitals. I come from this industry and been here for about 20 years. Where do you see robots at what point taking over the hospital cleaning? Because I think that's what's happening right now in a lot of places. Somebody yesterday spoke about Germany, where a hospital was managed by three of them and the rest of the work being done by the robots.
Yeah.
How long do you think this would happen before we can get to see this in India? Or is there a way that is going to happen in India?
I missed part of the question in terms of the infections.
Yeah, we're looking at this. It's always the biggest challenge we've seen in India: cross-contamination, infections, and the failures of patients in the hospitals more because of the post-care. And this is basically because of contamination, nothing else.
Sure.
India has always lacked in training of people in this matter. But however you say, cleanliness is always a priority here.
Right. It's a good question, I think, and just so you know, the US hasn't figured it out completely too. We still have surgical site infections. We still have a lot of airflow-based infections. I think a lot of it is awareness. Cleanliness is not just things that you put in place, it's the protocol and education that happens after that with your facilities management and your nursing staff. And so data like this that shows as the top of mind concern, education programs, and more informed decision making, both on the design so that you reduce affordances for contamination, that would help tremendously. I could see this happen in the next 5 years, right? I don't think it's a target that's difficult to achieve. It's just the awareness around it.
Do you see robots taking over the industry?
Okay, I think we'll have to do a hard stop.
We have to do a hard stop.
That's a breakout question then.
But Mr. Gaurav and Dr. Upali, please be on the stage for just a minute longer. So it turned out to be a very fascinating and interesting discussion. I can see that there are a lot more questions. We have to take them offline. And I'm sure both our guests will be available at least till lunchtime or thereabout to take all of the questions and be a part of the further discussions. And I think one of the key takeaways from me was that very good quote which you mentioned on when it comes to data, there is more noise than signal. I think that was quite a good point, and if with your permission, I will use that in one of my future speeches. Sure. So I hope you don't mind.
I use SketchUp, you can use the data, we're good.
We are mutuals. But can we please have a round of applause for both of our guests from HKS? And as a token of our appreciation, I would like to request Dr. Vivek Desai from HOSMAC. HOSMAC, by the way, is our knowledge partner, to hand over a small memento to both Mr. Gaurav Chopra and Dr. Upali Nanda. And
as always, rich in experience and rich in knowledge.
Thank you so much.
And just so you know, this memento was taken live. This is a photo of you speaking at the event just now.
Oh, wow. Thank you so much.